the female partner was normal. In summary, the young couple with total motor sperm count of 5 million. He had bilateral varicocele, which is recurrence on the left side, with normal female evaluation. What would you manage and how would you manage this case? What will you do? Would you follow up the patients or give some empirical medical treatment? Would you just forward the couples to IUI or ICSI, or would you fix the varicocele, recurrent varicocele? According to the guidelines, no reason for waiting after 3 years because the couple has been trying to conceive for 3 years. What about empirical medical treatment? Would anybody give any medical treatment to this case? You?
Yeah.
What would you do?
So, in this case, we
So
have
he has 5 million total
Yeah.
motor sperm count
yeah,
with bilateral varicocele.
indeed, he has bilateral, but was operate only one side, so that the chance that there's a reflex from right or left still existed from the beginning on. So I'm assuming that for many years before they had on the right side too, which was not checked. Secondly, we missed information about the AMH and the over function, but we assume that the lady is well far down. I think we will go to the option that we have to reoperate him, and before we reoperate for a scheduling time, it doesn't matter if you're doing the operation in 3 months or 6 months, so I will start right now with the antioxidant and then make the varicocelectomy.
Yes, the treatment just should depend on the couple's situation.
Correct.
But the guidelines don't suggest any empirical
Indeed,
treatment.
if you ask me for the empirical medical treatment, so for clomifene and amortazine, no, I would not say tamoxifen, there's no way. But antioxidant according to the GAF study, would say yes, it's a
Yes,
good
but
option.
I didn't mention, but SFTI just could be measured in this case, but we don't know. No IUI because of the couple will have only 5% chance with this total motor sperm count. What about treatment of varicocele or ICSI? So it will depend on patients, the couple's situation. If the couple just wants to conceive naturally, treatment of varicocele would be the first option. If the couples just chooses directly ICSI, and it will be okay. Even if we do our best in the treatment of varicocele in infertile male, we will have only response in just half of the men who will undergo varicocele treatment. The rest will not have any response to treatment because of these reasons, genetic reasons in 10% hormonal dysfunction, recurrence, unexplained infertility, or any other molecular defect if diagnosed. So therefore, we should choose good and the best method to treat these men with recurrent varicocele. It's important. There are some controversial issues in the treatment of in the management of infertile men with recurrent varicocele regarding why and when and how to treat these guys. What will be prognosis after the treatment of recurrent varicocele? For example, this case is oligospermic in the presence of recurrent varicocele. Would you just use ejaculated sperm for this patient? Not patient, just general patient, oligo or very oligo or extremely oligospermic patients. Or in the presence of isospermia and recurrent varicocele, would you fix the recurrent varicocele before ICSI? Because about 1/3 will have some sperm in their ejaculate after the treatment of varicocele. Then those sperm can be used for ICSI, or would you forward the patients to undergo microTCR directly? Again, let's say a case who had no sperm on primary TC procedure, Dr. Kopi could find a sperm in this case, but in the presence of recurrent varicocele, would you just give any medical treatment to patient or just perform radiovaricocectomy or wait for some future treatments like stem cell or another kind of treatments. Recurrent varicocele should be evaluated at 6 to 12 months after initial treatment in the presence of no improvement in semen parameters and not achieving pregnancy, and the presence of IVF unsuccess, and also just persistence of the testicular volume loss in adolescents who had primary treatment. Looking at the reasons for recurrence of varicocele, we see as the reason just in unligated internal spermatic vein channels in 2/3 of the patients, and also during radiovaricocele repair we also see unligated external spermatic vein in 1/3 of the cases. So we don't see any recurrence due to unligated gubernacular veins. Looking at the treatment of recurrent or persistent varicocele, we could perform surgery, radiologic treatment, and we could only follow up them. Looking at the surgical methods, so if we use microscopic procedure or laparoscopy, we will be unable to ligate external spermatic vein during laparoscopic surgery. And if we just perform macroscopic inguinal surgery, we can miss some very small channel of internal spermatic veins. Therefore, we should use magnification to see unmissed, to see and very small unligated internal spermatic veins, also to ligate external spermatic vein. Radiologic embolization, I have not. We don't use radiologic embolization in recurrent cases, but some echoes, some colleagues will perform, because even the radiologic treatment has some advantages and disadvantages. Technical failure is too high, especially in the bilateral cases. And here you can see if the internal spermatic vein drains into renal vein directly as one channel. It's easy, no matter how method you use, but if the patient like this and like here, a lot of small internal spermatic vein channels, it will be difficult to ligate all internal spermatic veins macroscopically. Here is a case, this case, with left varicocele who had primary treatment, and we can use the same incision. If the patient had high inguinal incision, we can go down to just subinguinal or inguinal level. If the patient had subinguinal incision, we can use the same incision, or we can go a little bit up to achieve to the proximal level of internal spermatic vein. Here we should see the external spermatic vein if it is ligated or not. Then under microscope we can use, here you can see the patient was like level ligated here. You can see all artery here, veins at the same time. I think I can show this video because it will take long time in my other presentation. So all internal spermatic veins should be ligated. We have had more than 200 cases with recurrent or persistent varicocele. More than half got radio operation, and some were followed only conservatively. What we found was the pregnancy rate was significantly higher in patients who had radiovaricocele repair than in the control group. The miscarriage rate also, varicocele radio repair decreased miscarriage rate. As you can see, this is not significantly, but very difference between the two. So microsurgical radiovaricocelectomy can improve postoperative sperm parameters, serum gonadal hormones, and also spontaneous pregnancy rates. And then we just published a systematic review consisting of 21 papers. And here you can see surgical methods provided more success than radiological intervention, and also the total improvement in total motor sperm count was significantly higher in the methods who were treated with surgically than the patients treated radiologically. And the pregnancy rate significantly increases after surgery than in the radiological treatment. Another paper another meta-analysis included 7 papers, and what they found was, again, radiovaricocectomy is a safe and effective treatment option for men with recurrence of varicocele. Finally, the last systematic review included 18 studies with more than 1,000 patients. The operations were performed due to infertility and some pain treatment. So repeat treatment for persistent or recurrent varicocele is feasible, and the rate of success was high. Here, just pain was dissolved in more than 90% of patients who had radiovaricocele repair, and pregnancy was ranging from 17 to 58 with almost 900% of improvement in sperm parameters. But of course there are some complications, including hydrocele testicular atrophy, but not less than 10%, more than 10%. In conclusion, recurrence of persistent or varicocele should be treated if the couple wants to conceive naturally, and scrotal Doppler ultrasound is always necessary to confirm recurrence of varicoceles. Just surgical methods have higher pregnancy rate than radiological treatments. When we treat varicocele, we should pay attention for unligated, also external spermatic veins. Comparing all the techniques, microsurgical radiovaricocele repair has the lowest recurrence, hydrocele, and testicular atrophy rates in the treatment of recurrent varicocele. I finished my first case. If there are any question related to treatment of recurrent varicocele or any comment?
Do you perform ductus deferens via ligated?
No, not necessary, because not reason to just ligate vas deferens, because when you just ligate internal spermatic artery branches during the surgery, so it should be necessary to preserve basal artery. So it's not easy to differentiate from around the vas deferens complex. So it's not necessary to ligate, but differential. In order to preserve also in differential artery.
Do you propose for your patient to freeze their sperm before operating in case of oligospermia or oligospermia?
No, not necessary. Maybe it could be necessary for patients with pellet positive azoospermia. Not necessary in this case, for example. With
No, in general.
No. Do you perform sperm?
No,
Do you
it's an indication. So
preserve?
no, it's expensive. Say no reason.
Right.
Because I'm trusting my approach.
We don't
It's
expect to see
Yeah.
azoospermia after radiovaricocele repair. But sometimes some men with cryptozoospermia also have pellet negative situation, but naturally, not related to the surgery.
Yeah.
Yes. Yes.
So I liked your presentation because it highlights different issues more. One of them has been the impact of the varicocele on the recurrence, pregnancy loss, highly different. That's
Yes,
highly
but
important.
it was not statistically significant, but
Yeah, but
some
it's a
papers
pretty big
say
figure.
report significant different, some
1990
not.
study from Farala, and it was important. Even as I'm doing most of the cases, I preferred for several reasons a microscopic, microsurgical intervention. There is the question if in the case of a bilateral, it's not a good option to opt for a laparoscopic approach as long as you have a Doppler intraoperative to preserve the artery. So because they have one approach, you can go left and right side. It's surely fast because it's done in 30 minutes, 40 minutes. A bilateral varicosectomy gives you more time, up to 3 hours. So I think that's only a question that I'm always addressing to myself. If I should switch for these cases and do immediately at least the primary bilateral varicocele and make a laparoscopic approach.
If you are sure the reason for recurrence of varicocele is elongated interspermatic veins on Doppler ultrasound, you know very well, it's easy to do laparoscopic method. But if you are not sure, because it's not easy to achieve to external spermatic vein during laparoscopic surgery. Any laparoscopic surgeon here perform laparoscopic procedure? What do you think about that? Is it easy to, like, it's not like robotic vasovasostomy or vasoepididymostomy. Is it easy to achieve to external spermatic vein?
It's basically it's easy.
Not internal.
Now external.
Lowest level.
Yeah, but I think it's enough if you go into the internal ring.
Extraperitoneal.
Yeah, you can go to the internal ring and make 2 clips, and as long as you preserve the artery, so you have to be only careful by opening the fasciate first line, take it out, and they have 1 or 2 veins, not more. So, but in bilateral, I'm always thinking about what's the best approach. I'm not sure. I prefer also doing microscopic everything, but I think that's the indication where I would opt in. And if not working, then I would go for microsurgery.
Okay, the meta-analysis reports the highest improvement
High-
in
highly important.
microsurgical or open surgery.
Yeah, but it is it's highly important
Yes.
your lecture because you see my doubts and I learned that how you can do it better.
Okay, let's present the second case, who is azoospermic case. The couple has been trying to conceive, and the male's physical examination showed almost normal testicular volume with again bilateral primary varicocele. His FSH level was a little bit high, but in normal range again with normal total testosterone level. Semen analysis showed azoospermia, pellet negative, no sperm, any sperm in the ejaculae, with normal genetic test showing only karyotype, no karyotype abnormality and no Y chromosome microdeletion. So he had micro-TC procedure with no sperm, but the biopsy showed us rare spermatid here, very rarely. Spermatocyte, but here very spermatid, no sperm. So how would you manage this patient? The patient just wants to try again. What would you do in this case? Azoospermic case, 1 failed TC, micro TC, not conventional TC procedure. Biopsy showing rarely spermatid. Would you actually? I'm sorry, I'm green, but it was my choice. But I think all answers are true. Everybody just can perform different way up the couples. Would you wait? No, waiting. Would you perform varicocelectomy before micro-TC procedure? Would you use spermatid injected for ROSI? And also, would you give any empirical or any kind of medical treatment at the time of second procedure or on the day? I think B, C and D are correct, but just what literature say in this case, clinical characteristics of men with maturation arrest, this group of patients are always surprising to us because with normal testicular volume, almost normal serum hormonal levels, and there is no any genetic reason to see. So when we see his FSH level of in normal range, so we expect to find sperm in this case, but the patient had no sperm on primary micro-TC procedure. Looking at the etiologies here, so we cannot correct most of them, only there is some reasons to get no sperm in this case, like varicocele, some kind of radiotherapy, medications like chemotherapy, aging, and systemic disease. What the guidelines say here? Nothing on this case. Would you just perform hormonal therapy before second TC procedure? The AUA doesn't support any treatment, doesn't suggest any treatment. Also EAU, no routine therapy in this case. Looking at the literature or studies, including some meta-analysis, the sperm retrieval rate is about 69% in cases who had varicocele repair before TC, or and 27%, but in this primary cases here, just to improve spermatogenesis. But the case had micro-TC procedure with no sperm and wants to try again. Another study just showing varicocele repair significantly increases sperm retrieval rate and also live birth rates. Looking at the medical treatment according to the guidelines, again, the EAU guidelines don't suggest any treatment before micro-TC in this procedure because the patient had normal total testosterone level. Just looking at the GAF expert recommendations, if the quality of evidence supporting hormonal therapy before testicular sperm retrieval is low, but however it may improve sperm retrieval rates in some patients with non-obstructive azoospermia. Exogenous testosterone should not be used for men with non-obstructive azoospermia who are still interested in testicular sperm retrieval procedures. But if you just prefer to give any medical treatment, these would be an option to treat these patients. Any kind of gonadotropin injections or aromatase inhibitors, not selective estrogen receptor blockers, because the patient has normal, a little bit up to normal FSH level. Looking at the sperm retrieval rates in this case, primary cases just to find sperm range from 29 to 90% almost, but the success rate is about 20% in secondary TC procedure. Yesterday, Dr. Kolpi presented some cases who failed for first TC and found some sperm. So the rate was almost 20% to find sperm. So we are not going to find any sperm in 80% of the cases who had primary TC which fails sport. So the guide related to the timing of repeat surgical sperm retrieval, what do you think? When should the couple have the second TC procedure? The GAF survey says not that's an optimal timing for repeat TC procedure. Which technique would be the ideal to perform second TC? Of course, everybody can perform FNA, for example. Even in the United States, some colleagues again performed 5 fine needle aspiration for the second cases, but according to the Gulf survey, the majority want to perform micro TC procedure. What just will be the predictors for successful sperm retrieval in these cases? There are two different methods. Testicular volume, if the negative predictors in the presence of testicular volume of less than 5 ml with serum FSH level of more than 10 international units, with total testosterone level of less than 3 nanogram per ml, and if the testis histology shows us germ cell aplasia, it means we have very limited chance to find sperm for second TC. If the testicular volume is more than 5 ml with the presence of less than 10 unit of FSH level with more than 3 nanogram per ml of total testosterone level and showing biopsy hypospermatogenesis or maturation arrest at the spermatid level, not spermatocyte. So sorry about that. And we have higher chance to find testicular sperm in these cases. My last slides just to differentiate obstruction and from non-obstruction, and it's easy to get history, physical examination and hormonal assessment. So if vas deferens is palpable, then we should consider the presence of congenital absence of vas deferens. If the vas deferens is undefined, and we should check ejaculate volume. If the ejaculate volume is less than 1.4 ml, then radiologic TRAS should be considered to detect presence of ejaculatory duct obstruction. If the hormonal gonadotropin levels are high, then we should consider the presence of hypogonadotropic hypogonadism or hypergonadotropic hypogonadism. If all hormone levels are too low, then we should consider the treatment of hypogonadotropic hypogonadism. In the presence of higher FSH and LH or only FSH level, then we should use testicular biopsy in part of micro-TC procedure. I think it's enough for my time because my edo cases was overlapping with you. It's enough to discuss.
Professor Cayan, what do you think about the anti-Mullerian hormone as a predictive marker?
For female or for male?
For male.
For male.
Before, as predictive model, before assessment.
Like yesterday, asked the inhibin B level. I think it's not easy and not cheap to perform to use for in the general panel as anti-Mullerian hormone. I don't use anti-Mullerian hormone as a predictor of male. But what do you think about this?
I don't use it. Well, the problem is that we read in the literature so many papers about predictive factors, but really the conclusion is there is no predictive factor, no sure predictive factor. There is only probability factors, and so if you have only probability factors and above all, also the conclusion of the surgical operation depends on you and your team of biologists. So it is better that you explain to the patient that you cannot guarantee a positive result, but maybe it is better to try to attempt a retrieval and you do your work.
Any other question related to the last case?
I can answer the question. So I'm not doing measurement routinely for different pharmacological reasons. We have AMH as a hormone and AMH receptor. both can have to be differentiated and both have to be checked in this case. So it's not only one MH to check. And therefore it becomes too complicated for me, and therefore I don't use it. But basically, only to check the hormone in this case may be not a problem. So we learned the same for testosterone. We never trust the hormone testosterone itself, rather the free testosterone. In case of unclear situation, we're going to check the CAA repeats on the genetic information, and if that's 27, 25, so it's fine. If we see a few repeats on the testosterone receptor, we're going to ask for the Kennedy syndromes in the order of 45, 50, and know exactly. If they have a high testosterone, it will never affect because you have the receptors at work. This is a function question, and you cannot assess the function question so easily for the AMH. So therefore, I'm not doing it.
Okay.
Do you have any idea about the number of attempts of redo microdose? Because we read in the literature that the more we attempt, the more we have the death toll.
Attempt meaning time or just puncture?
How many times, how
how
many
many?
microthesis?
Microtest procedure could be performed.
And what is the time between
I think
each
the
microthesis?
success rate is about 20% with second TC, should be less than 10% with third micro TC. Another concern will be for patients who had sperm on first micro TC, and what will be your chance to find sperm with second TC. Dr. Kolpi just showed us yesterday some patients who had no sperm on primary TC and he found, but just contrary. What do you think about that? First, so what will be your chance? What will be your chance to find sperm in cases who had sperm and used for ICSI on primary TC? So you are performing second TC.
Well,
Do you always 100% success?
I showed a case where I had the positive sperm retrieval by microtase. It was the fifth case, okay, and but the sperm, the retrieval was poor, and we could perform only two ICSI procedures, two blastocyst, and then no positive outcome, so I had to operate again the patient. But in that case, I operated on the left testis, which remained untouched during the post-operation. Okay, so I checked 2 years ago my case series about the possibility of finding sperm by microtase in a patient already not naive, that is already operated by other surgeons, either by needle aspiration, multiple needle aspiration, or by teasing. And the result is that we have about 43% of positive sperm retrieval by microtase in these non-naive patients. Okay, so generally speaking, I will explain something now about this topic, a specific topic in my presentation on the gap management guidelines, NOAA. Okay, and so we can discuss appropriately. Okay.
So in summary, we can say the first test TC, the success rate will be ranging from 20% to 80%. For the second TC procedure, is about 20%. For the third procedure, is almost less than 5%. So it means no shouldn't be repeated after third TC. Third is enough, right?
If you have a good biologist helping you, and he or she can refer you directly if your level appears high or poor. Clearly, you have probably you will not need to perform a second microtase probably. Okay, but well, maybe that sometimes it happens that only few sperm, only one sperm, okay, and you realize that there is an incomplete maturation arrest. This is the most complicated cases, really, the most complicated cases in my opinion. And in this case, maybe that if you use your sperm and you have no success, you are obliged to repeat them again. But I will discuss also this point in the next presentation.
Dr. Constantine, please.
Thank you very much, Professor Cayan, for sharing this interesting thesis.